Okay, let's get started. Today's conference is going to be on bone graft substitutes, and just one more, remember, everything is posted on the internet, so Cameron, keep your comments rated PG-13. Okay? All right. So, and the reason why I think we should go over bone graft substitutes is it's such a hot topic. And right, Peggy, is this the hottest topic in the blood banks?
Yes.
Nothing's close. Every day we talk about bone graft substitutes and costs and
every day, all day.
Who's the biggest driver? Like, why do you talk about it?
Because it keeps coming in, the putty, all new tissue keeps coming in.
So just the volume, the volume of the new tissues that are coming in,
and the growth of the spinal center,
and the growth of spine surgeries,
and
orthopedics, right? Okay, so that's a big push of the hospital for us to be a bigger spine and orthopedic center, and also these products are new. I think there's 250 products. How many do we carry?
I didn't count them.
There's 250 in the United States. Allograft products.
Okay, so we probably carry
about 10. 20?
At least, I was thinking 50.
50? We carry a lot. Okay,
Yes, we do.
that's a lot to keep track of. So that's why I think we should talk about it. Why do we use them? What are they? Where do they come from? So this is just an example. This slide is an example of my favorite, because it's who knows what this is? Tricortical femoral ring allograft, right? So it's a piece of femur, and you cut a slice of it. And you see the middle, and what's another thing that people call this? Orthopedics would like to call things different things. Dog bone, right? So, so you understand when you eat steaks, you know when you eat a steak, what's the steak called when you have one of these things in the middle? Ribeye? No.
Porterhouse?
T-bone?
T-bone? No, T-bone's not T-bone. T-bone's got a T in it. What is it? Ribeye, isn't it?
Bone and ribeye.
Yeah, bone and ribeye. Yeah, and there's marrow in the middle. My mother used to make me suck the middle of it. She said it gives you strength, because in Greece they didn't have meat.
Did it work?
Yeah, look at these big muscles.
What if it's it?
So it's a tricortical femoral ring allograft, and this is mostly used when we do anterior lumbar interbody fusions. Anyway, it's the old way. I still do it that way, and I do it because it's cheap. Although it's not as cheap as I thought it was. The femur costs. Remember. We said it was $800, right? These are Upper Chesapeake prices, 2012.
Okay, I thought it was 12, but
Is it $1,200?
yeah, I thought so.
That's femoral head, I
So
thought.
just a piece of that is 1,200?
Well, they give you a nice slice, like 5 centimeter slice, because we may have to cut it a couple times
Okay.
if we get it wrong.
All right.
Because usually the height of the disc is 14 millimeters approximately, and so we want like a 5 centimeter piece just in case we have to make a couple cuts. How much is it, Peggy? You don't know?
No. We went over this the other day. Remember I said
We couldn't find out, yeah. Well, it's probably $1,000. Now, if you cut the cortex, this is what you see on the under a microscope, and this is mature bone, and it's lamellar bone, and in the middle of the hole is where the nutrient artery and maybe nerve runs. That gives the bone supply, the bone blood supply, and these little things. Who can guess what these little dots are? These are the osteocytes, or the cells that are within the bone that give the bone life, basically. And these are all calcium hydroxyapatite and collagen. In this you can see it's very organized, very smooth. That's cortical bone. This is the cortex, this hard part, and this is more the cancellous inner part. So this is the cortical bone, what it looks like. And bone has another aspect of it, cancellous bone. And the cancellous bone is this portion of the bone, the middle part or spongy part, and it's made up of trabeculi. And this portion of the bone resists compressive forces the most, so that's why we find them in the joint. And you can see this is cortical bone here, and this is cancellous bone. Now, if you cut the cancellous portion of the bone, here are the trabeculi, and in the middle are is fat and hematopoietic cells, which make blood supply. So this is what trabecular bone looks like. Now, what are the different cells inside a bone? And if anybody wants to interrupt, just add something, just interrupt me, because I want everybody to understand what bones is all about. So there's osteocytes we talked about. Those are like I don't know how to characterize them, but more like they're kind of like the normal citizens that they just kind of hang out and they do the day-to-day things for bones. The osteoblasts, they have different jobs. The osteoblasts lay down bone, so they create new bone. And here they are, they're all lined up and they're creating new bone right here. See how they're making a new organized bone here? This is the organized bone with the little osteocytes. Now these are osteoclasts. And clast means when you break something, like a iconoclast. And the osteoclasts come from monocytes, or the blood supply, and they eat bone away. So these cells eat the bone away. So why would you want something to eat bone away? Seems a little destructive, right? Who can think of a reason?
Reforming.
Yeah, reforming. Yeah. So someone like Cammie, who lifts weights all the time, she needs strong bones because her body undergoes these big forces, right? When you lift weights, so you have to have strong bones. So your osteoclasts are always eating away and laying down more bone. But if you don't exercise, you don't regenerate new bone, and it's a problem. So the osteocytes, they sit in like a little lagoon, or lacuene, or whatever. How do you say it? And these are the osteoblasts. And this is the marrow space. So what's the rest of the bone made out of? Well, it's made out of calcium hydroxyapatite. So here's the chemical structure of calcium hydroxyapatite. Who remembers their chemistry? I mean, I certainly don't. But it's mostly like three phosphate groups and calcium. And this is collagen. So bone has collagen, which we find in like tendons and cartilage, type 2, but type 1 is what we find in bone. And the other thing is a very minor component is glycosaminoglycans, which is a complex sugar, which is kind of like mucus, and we have glycosaminoglycans everywhere in our cartilage. So how do these things all interact with each other? Well, calcium's in the bone too. So like 99% of our calcium is in bone, and it goes in and out of our bloodstream, and it's very important, and it's regulated by calcitonin and also by parathyroid hormone, and they act at the level of the osteoclasts and the osteoblasts. So the body is very complex. It's beyond my understanding, but there's a constant down and up regulating from these hormones that gives us bone formation. And this is a great micro photograph of the ruffled border of the osteoclast as it's eating away the bone. You see that? It looks destructive. And they come out of your cells, your blood, and this ruffled border is where it eats away a bone, and it eats it away with lysosomes. So when we take Fosamax, do you guys know what Fosamax is? Alendronate? Alendronate works at the level of the ruffled border of the osteoclast. So the way Fosamax works is it gets embedded in your bones, and it sits there, and when the osteoclasts go to eat the bone up, they get basically inactivated by the Fosamax. And the Fosamax stays in your bones. That's where it lives, in your bones. So once you stop the Fosamax is in your bones still, and it stays there forever, like 60 years, for you to get rid of all your Fosamax, alendronate. So that's how alendronate works, or Fosamax. And the problem with, remember we talked about it before, is that this process is kind of destroyed, this eating away and laying down bone. So you develop stress fractures with Fosamax after about 3 to 5 years. So most people say you shouldn't take Fosamax for more than 5 years now because of these risks. So any questions about osteoblasts, osteocytes, osteoclasts, bone? And the way that the bone remodels, so when Cammie goes to the gym and does her exercise, she makes her bones stronger, and it happens with cutting cones. On the outside, this is all bone, and what happens is these osteoclasts rip through the bone in these cones. And these are all the osteoclasts eat the bone, all the osteoblasts come up behind it and lay down new bone, and that's how new bone is formed. This is a better photo, which shows the osteoclasts in the front. This thing is the cutting cone, and the osteoblasts are behind them laying down bone. And see, this is mature bone that the osteoblasts are creating. And this whole thing is called creeping substitution. So when you stick allograft into someone's bone, your own bone eats it up, basically. The osteoclasts eat it up, and then behind the osteoclasts are your own osteoblasts laying down your own new bone, so the whole thing gets incorporated and is gone. So if you I'll show you a CT scan of this example, but if you do like an ACDF with this allograft, it's gone after 4 or 5 years. That's why I like using allograft. And after, like, Joanne, if you see like a MRI from a ACDF that was done 10 years ago, what does it look like?
I don't know.
You've seen them, haven't you?
No, not necessarily.
Really?
We don't get the history, 10-year history. We don't.
Oh, it looks like just little bone. This is like your own, like a femur. So it gets incorporated, remodeled after 10 years, and the two vertebral bodies just look like one big long vertebral body.
Yeah, that's true.
So that's because of this creeping substitution.
Yes.
So how do the bones heal? So we're talking about bone substitutes, right, and about fusions. But I think it's better to understand it like a fracture. So fusions heal like a fracture heals. So if you break your thigh bone, it's going to heal up. So here's how a fracture heals. Here's the break, and it develops this big callus on the outside that slowly remodels and they unite. So here's like a defect from the injury, and then see how the callus starts to form around it, and then it grows on the other side, and then eventually it remodels into one big long bone. And this takes like a long time. And the way that you heal these bones is, and this process I think is the same thing as fusions, very similar anyway. First there's a hematoma, then there's granulation tissue, callus, it models, and then it remodels. So when you first fracture a bone, it gets inflamed for the first week or so, and then it goes under a process of repair that basically heals it. So at this point you're about 2 months. You're fused, but it's a very immature bone or woven bone. And then over the course of years it remodels. So if you have, kids do this a lot faster than adults, but if you have a fracture, after about 5 years, it usually looks very similar to a normal bone. And after like 20 years, usually you do not see any more deformity. It looks like a normal bone. It remodels itself. So the first couple days is inflammation, which is mostly blood cells, and then it becomes vascular, and it becomes this big clot, and it's full of fibroblasts. Then it repairs itself after 4 to 5 days, and that's when the mesenchymal cells come in from somewhere. And those are the pluripotential cells that they say is in Trinity. And those cells come from either their trabeculi of bone, some marrow, it can come from muscle, it can come from fat, but the best place is from the bone itself to get the mesenchymal cells that become osteoblasts and lay down bone formation. And then over the course of the years, the whole thing remodels. So the next question is, why are you telling all this stuff? I thought we were talking about bone substitutions. This is really boring fracture stuff. So let's show how it corresponds to spine. This is a patient of mine that was 30, and I had done an L4 to S1 fusion, and he came back a year later, and his back hurt, his severe pain. So is he just a drug seeker, or why do they come back a year later? Like what could be going on? Who can give me an answer? Anybody? Danwan? What's the cause of pain? Spine fusion, came back later.
It just may be afraid of fusion.
Yeah, failure of fusion. Yeah, and so he has a non-union. I'll tell you that now. And I have a personal theory of why it takes a year, because these people don't have immediate pain. They always come back after 6 months to a year. My personal theory is that's how long it takes for the nociceptive nerve fibers to grow into the non-union site to cause pain. And then, because the thing is, pain has to come from somewhere neurologically. There's no magical receptor that goes to the brain like a cell that says, it's got to come from a nerve. because that's how we process pain. So it takes a year for the nerve fibers to grow into the non-union area, and for some reason non-unions are painful. The nociceptors, the motion there is abnormal, and it gives people pain. And I think it takes a year for the nerves to grow into the area to have pain, because non-unions don't come back after a month or 2 months or 6 months. It's always a year, 6 months to a year. So this guy came a year later, and here's his CAT scan at 5'1", which is a very solid. Well, Joanne, what do you think here of the CAT scan?
Yeah, I think you've got a lot of hypertrophic bony tissue around the posterior rods and pedicle screws, and it looks solid.
So very solid. This is where the facet used to be. See how there's bone going across it? And the transverse process is connected to the lamina, is connected to the transverse process, and a solid bone. Now, how about this is at 5'1"?
Right.
How about at 4'5"?
At 4'5", you see a gap in what is the facet joints.
See the line? So
which
this
is much wider.
So the facets, they kind of look like a little bit like hamburgers. I'm a big hamburger fan. See how they look like hamburgers? And the middle where the meat would be between the two buns is the facet joint, and that facet joint is still there.
Right.
It should be healed.
You also see a line going out laterally from the posterior rod, laterally through there.
So
there's a pseudo-articulation between all that hypertrophic tissue.
That's not healed. And look, this is definitely not healed.
Yes.
Okay, so he's got a L4, L5 non-union. How about this? How about the sagittal cuts, Joanne?
Oh yeah, you have another fracture through what would probably be the Scotty dog, the pars interarticularis.
Here's the line through the facet, and here's the line through the pars.
Yes.
Now look at the fusion here.
That looks pretty solid.
Pretty solid. See, the two facets are fused. And these are just more of the same. And here are coronal sections. What do you think here, Joanne? 5'1"?
Again, 5'1" looks pretty well fused, and then 4'5", you can follow basically a line, jagged line across
where it didn't heal.
Articulation or articulation bilaterally.
And in surgery, just so you know, non-unions, they don't go through a straight line. They have we call it serpiginous. We like to use long words, serpiginous route or snake-like route. So it's like you have to like follow the whole track all the way through.
Just a dumb question. As you're talking about the general formation of this callus, and I mean, as you go through the stages of being more fibrotic tissue or soft tissue, and then progressing to more rigid bony tissue, could you have a subsequent kind of acute fracture at the 1 year mark because the tissue itself is more rigid at that point?
I mean, can you heal a fusion and then fracture through a fusion?
Yeah.
I've seen it at shock trauma once. A girl had scoliosis surgery, was fused, and she had a T8 fracture through her fusion mass. It was amazing. You can fracture, just like you can fracture your femur, you can fracture through a fusion mass. But is that your question, or are you saying more like if it's an immature fusion?
Well, you see these people at a 1 year mark very frequently. So the question is, have they had this non-union continuously over that last year?
Yes.
Or did they more?
You can't. I mean, when you have screws across, when you have implants across a non-union site, there's very little motion there because the screws keep things still.
Right.
But what happens is about the screw, the bone moves, and then the screw doesn't work anymore. It's lost its fixation because it's wiggling basically.
Right.
So there is motion, but it's very minimal motion. So we're talking like just a couple millimeters. When we do these non-union cases, there's millimeters of motion, which is, I mean, physically it's inconsequential, but it's enough to cause pain.
But you see these people at a 1 year mark, and I mean, I've seen a couple where you see a discrete line across,
Okay.
and if it is potentially
It's been there forever.
versus sometimes fractures that are angry fractures are more hypertrophic and.
Well, that's a different fracture type you're calling. That's like a hypertrophic non-union, where
It's continuing to have
micromotion. Yeah, a lot of micromotion, and it has callus. Right. That's what happens with a pars fracture.
Right.
You get a lot of motion in a pars fracture, and you develop a lot of callus, but it never heals.
Right.
But in non-unions with implants, there's not that much motion there, and because there's not that much motion, you don't lay down a lot of callus.
So okay.
You understand? So like if you have a plate and you have a non-union through the plate, a plated femur, you don't develop callus. The plate breaks and there's just a line there. But if you have have you seen a hypertrophic non-union?
Yeah, where you just have
there's a massive. Yeah. Does everybody know what we're talking about? Actually, I can pull it up if you want. If we go this is the power of the internet.
Sorry.
Huh? No, it's an interesting topic. If you
Well, in my reports, I say this looks somewhat more recent, and your theory is it's not recent. It's just a progression of.
This is a hypertrophic non-union. Oops. See this massive callus there? And this thing doesn't hold the tibia very still. It's just like a long wire. It moves a lot. So see how it forms a lot of bone? But even though it's formed all this bone, there's still a line across it. It hasn't healed.
Right.
See that? That's what you're talking about, right?
Yeah, it's not, I mean, I make my guess as to acuity based on how sharp the line is. And
What?
So.
What would you say this is? Acute? That's a hypertrophic non-union,
Yeah,
big
no,
callus.
that would be more chronic because you see the hypertrophic edges and the callus formation about it. But if you have a
What's your question? I'm not following you.
that's okay. It's a case that I'm just questioning. A question about you say that the presentation is a year later typically, and that's
Right.
And
For pain, the pain comes a year later.
Okay.
The radiographic findings are there always.
Okay.
So pain's got to come from somewhere,
Right.
Anatomically, and it's got to come from nerve fibers. It doesn't. Pain doesn't come. An anatomical pain has to come from a nerve fiber.
Right.
I mean, psychological pain can come from your brain, but like if your
Yeah.
girlfriend breaks up with you or something, but like joint pain has to come, you
Right.
know. And there's no nerves there. There's no innervation. It takes time for things to get reinnervated.
Okay.
Does that make sense?
Yeah.
I mean, that's my personal theory. No one's ever talked about it because I don't know why people don't talk about it. Okay, let's keep going. So these are how bones form. And Peggy, this is important for you so you can understand like what all this is. First, you need stability. Something's got to hold the bone still. If it's slopping, it's moving around, it's never going to heal. You need osteoconduction, which Kemi was telling us is the scaffold. So it's kind of like a scaffold for the bone to heal. You need osteoinduction, which are growth factors, basically BMP. Nothing else works. BMP is really what makes bones heal, is the hormone that makes bones heals. And you need cells to do it. Remember those osteoblasts? So they don't come from, God doesn't send those cells down into your body. That comes from your body itself. The cells come from pluripotential cells and become the osteoblasts, osteoclasts, osteocytes. So one more time is you need a scaffold, and the scaffold is basically calcium hydroxyapatite. You need cells, and the osteoprogenitor cells, so the cells that make osteoblasts, osteoclasts, all that, are best found in the trabeculum. Remember the trabecular bone? But they're also in the periosteum, and of course, kids have really thick periosteum, and periosteum is a very rich source of bone-forming cells. In fact, if you when you stick an antibiotic spacer into an infection and it creates this big periosteum around it, that periosteum can form bone. If you take that periosteum out and put it somewhere else, it's got bone-forming cells in it. So periosteum is bone-forming cells. The cells also come from marrow and fat and muscle, but the cells from fat and muscle don't work so well as the trabecular bone ones do for some reason. And you need like around 100 million osteoprogenitor cells to get effective bone formation. You need a lot of them. So again, these are the cells we talked about. And the osteoinductive factors, they're hormones that make everybody talk to each other and recruit people and make the cells work together to get the bones to heal. So this is the old way to get bone, is iliac crest. So iliac crest posterior iliac crest is the best substance for bone. Now, why not do this all the time? Well, first of all, it takes time. It takes about, Eric, how long does it take us to do a iliac crest?
20 minutes.
20 minutes, right? And it also can cause pain. So the other complications you can have from a bone graft is it takes the surgeon 20 minutes. Like, we want to get done. We want to go home and whatever, play golf or, things that, doctors do. You can also get what?
Increased morbidity.
Right, increased morbidity, hematomas, infections, nerve injuries, pain from the bone graft site. And sometimes there's not enough bone there. So we've done a lot of cases where it's not enough bone. This person has no bone. Usually it's women because they're osteoporotic. There's not enough bone here. Like, what are we going to do now? And then, you know, in some cases you need a lot of bone, like if it's a big fusion. Now, there's a couple things. The posterior iliac crest, there's a fascia that goes, there's something that attaches here, and it's the gluteal musculature. So I think it's very important to reoppose the fascia, otherwise you lose the strength of your buttocks. And if you don't have a strong gluteal musculature, that's a problem. Like Megan, what if you don't have a gluteal musculature, what can you not do? What happens?
Usually you get a lateral lean with gait, so it's going to throw your gait pattern off. It decreases your stability around your pelvis. I mean, it really throws.
So when you walk, so the point is, when you walk on one foot, single leg stance,
you drop your hip.
yeah, you have to have strong hip abductors to keep your leg up. Otherwise, you flop. If you have weak abductors, unless you know orthopedics, you don't understand.
There's a Trendelenburg gait.
You get a Trendelenburg gait, exactly.
Or a lateral lean, because the Trendelenburg is the hip drop, where the lateral lean is.
Lateral lean is when you cheat and you lean, yeah.
over to decrease the lever arm so that you shorten it, so you don't have to use as much of it.
Right. Now I personally, I think iliac crest works fine, and I don't think people get pain. And I'll tell you why. That's my opinion. When people point to their PSIS or sacroiliac joint, that's like a final common denominator, or I don't know how to say it, final ending point of all pain in the spine. So if you have facet joint pain, if you have nerve pain, if you have disc pain, if you have a fracture of your lumbar spine, if you have sacroiliac joint pain, all of it refers to the same area over your SI joint. That's where patients point. So it could be anything. When patients point there, it could be anything. So I think bone graft gets a bad rap because they may not have bone graft pain. It could be any kind of back pain refers there. So bone graft gets a bad rap for that. There's a couple of things. Also, I think if you go through the midline incision, you have a lower incidence of injuring the superior cluneal nerves. See these nerves here? So if you make an incision right over the crest, it makes it easier for the surgeon. You can injure these nerves, and that can be a source of pain. So I always go through the midline and then tunnel under the lumbar dorsal fascia. So I think there's less pain.
You have a
long incision, yeah, long straight incision. Then the other thing is I just take a dorsal cap of bone. And why? Because I don't want to disrupt all the gluteal musculature so people don't have a problem walking, like Megan was saying. And then once I take the dorsal cap of bone away, then I dig out all this cancellous bone, which is the good bone, which is trabecular bone. And I try to avoid the sacroiliac joint. And sometimes I get into the sacroiliac joint, I see a white cap of, like a white cartilage. And Eric's like, uh-oh, you're in the SI joint. I'm like, oh, sorry. And I just try to be a little more careful. And then when I'm done, this bone graft, there's a hole here. There's like a big hole. And for most of my career, I did nothing about it until this one rep said, hey, can you use my product and put it into the bone graft site so patients don't have pain? I was like, that's interesting. I should probably do that. So I don't use the product, but it gave me an idea. I use Allograft now because it's cheap. Because I'm very frugal. I'm a very cheap person. So I backfill all these grafts now. And this woman was like a year and a half, 2 years out. Look at her ilium. It looks totally normal, doesn't it? Almost totally normal. So I backfill.
You have this bone there from there, right?
Yeah, I took bone from here 2 years ago.
All right.
And I got a CAT scan for another reason. But you can see it's basically healed. So it looks beautiful. So you can, and then the other thing is, I think if you don't have bone in that area, it could cause microfractures. It could be a cause of pain. So if you backfill it, the patients are fine. And here you can even almost make out the cancellous allograft cube. You see that I'd stuck in there. The other reason why the surgeons don't like to do bone graft is it takes a long time and it doesn't pay anything. It pays the CPT average is $181, but it pays about $120. I'll tell you, because I looked at my bills. So the surgeon's like, I don't feel like doing this. I only get paid $120. I'll just squirt the stuff in. It takes me 2 seconds to squirt the stuff in, and then we get out of Dodge and get to the next case. So it doesn't pay well. So you save a lot of time by just using the substitute. Does that make sense? Now, Peggy's all sorts of gears are rolling now. She understands why we use these grafts so much. So if you don't want to use the bone graft, what else can you use? Well, you can use demineralized bone matrix, which is basically, you can use allograft, which is bone from a dead person. You can use demineralized bone matrix. So you take the dead person's bone, take the calcium out, and that's what it is, demineralized bone matrix. And all it is minerals. You can inject marrow And the problem with injecting marrow is, first of all, it takes forever. You got to do it real slow, and you can only do it in 2 cc aliquots. Otherwise, you don't get the correct cells. Don't ask me why that is, but that's when you but you don't get nowhere close to the number of cells that you need for a fusion. You need, like, remember, 100 million cells, and it doesn't really work that well. And then you can use BMP, which we'll talk about, and you can use the synthetic bone grafts like Cammie brought for us today, the calcium phosphates, collagen substrates. So these things are ceramics. So what is I forgot what a ceramic was. A ceramic is this is a vase, Don Juan, from the Ming Dynasty. I put this in for you. So this is a ceramic. So ceramic, by definition, is something that's inorganic, and you heat it up very, very hot, and then you cool it. That's a ceramic. And these ceramics that Cammie brought for bone graft are ceramics. So the next question is, what is BMP? So BMP is the hormone. Where did it come from? It came from this person right here. He's the one who discovered it at UCLA in 1965. So does everybody here know what a phonograph? Everybody here has used phonographs, right? Who's the youngest? Megan? Did you have one of these when you were growing up? So this is like what you used to listen to in 1965. This is what a phonograph used to look like. And he published in Science his first article that he used to take demineralized bone and stuck it in the muscle of a rabbit, and he created bone. And it first came out, this is the first BMP product, and which is Infuse, made by Medtronic, and it goes into an LT cage. That's how you're supposed to use it. I don't know what LT stands for. I just remember Lawrence Taylor cage. And it was FDA approved in 2002 for fusions through the abdomen, ALIF, from L4 to S1. And so here's the metal cage, and the BMP is in a collagen sponge. That's the only FDA approved use for BMP in the spine. It's also approved in 2004 for acute open tibia fractures with the intramedullary nailing within 14 days of the injury. That's the other FDA approved use. But everything else that we use BMP for, Infuse, Mastergraft, is off-label. So, but you know how the law works. You guys know how off-label uses work. As long as it's what we do is safe, and as long as what we do is effective, as doctors, we can do anything we want. We can do whatever we want to patients. We don't have to go by all these rules, these FDA-approved uses. So we can use aspirin, for headaches, or we can use aspirin for like stop blood clots. We can do whatever we want as long as what we're doing is safe and effective when something's on the market. But the problem with BMP is it costs a ton of money, and there are risks. So let me show you just a BMP risks. So for about, I'd say 5 years, I used BMP on almost every fusion case because it worked incredibly well to get the bones to heal. But I noticed a lot of complications. Here's one woman, I'll do this quickly because we went over this before in a previous lecture, but like a 45-year-old woman who had an infection, and her CAT scan, Joanne, what does a CAT scan show? Like, is it fused or not fused?
No, there's the L5 pedicle screw has a ring around it, so that looks like it's loose, and so does the on your left. I don't know how.
There's a ring.
Oriented. Yeah, there's also a ring around it. Looks
How
like
about-
it's loose, and that one and the one above it is out of the bone. So you've got a hypertrophic tissue to the medial aspect of the.
But focus on the bone. Is it fused?
Yes.
Unlikely. It looks like there's a loosened.
I'm catching you in a trap.
Yeah.
How about here? Is this
That looks fused.
This fused, right? Now there's no screw up here. So this is 3/4. 3/4 fused. And 4/5 fused. And see the solid, massive bone formation. She fused where I didn't put the BMP,
Okay.
but she also had this is a complicated case. But my point is that she fused it where I didn't want her to fuse there. So if
That's infection that caused that, right?
infection could have caused, I know, it could have caused that too. Other, where the infection may have. Oh man, my computer stalled. Hold on. Okay, we're back. So this all this thing came down around summer last year, 2011, where Ed Carnegie published all the complications for BMP in the Spine Journal in 2011, and the companies over-reported the complications for iliac crest and also under-reported the complications of BMP, and we went over all these complications. So then Senator Chuck Grassley said, "Whoa, send a letter to Medtronic, and you have to tell us why you held back all this information." And I don't know what's going. It's on a standstill, but people got retrograde ejaculation from BMP through the abdomen. Remember the swelling of the airways. Here's the, you can see the trachea is being compressed here by this big swollen air thing. You get the seromas. Here's a patient of mine, had a huge seroma in the neck that Eric opened up at the bedside. And here's another lower back seroma. Look at this massive seroma that we opened up. And here's a Psoas calcification. We talked about Joanne. See that calcium right there? And here's the MRI, the calcification. I thought it was a sarcoma. But then I thought back. I was like, wait a minute, that was from BMP. And remember I told you about the backfill? See how the backfill is going on right here? You can't see it on the CAT scan. So what other options do we have now? This is the option play. If you give the football to the quarterback, he runs here. He has the option of getting to the tailback or keep running, just so you guys were wondering. The options are iliac crest, local bone graft, allograft, BMP, demineralized bone matrix, ceramics, the tricalcium phosphates, and cells. So what do these things cost? A femur, which is great bone graft supply, is $1,400. The Cancellus allograft cubes, which is my favorite, is only $370. It's pretty reasonable. And the tricortical strip is $1,200. It's kind of expensive. This is what I use for all my ACDFs right now because I like it. It costs $1,300, which is, I was a little bit shocked. It's pretty kind of expensive. The outside is cortical, so when I tamp it into the space, it won't break. But the remaining portion is trabecular, which I like because I think there's a higher likelihood of this being incorporated quickly because it's trabecular bone, which is a very nice scaffold. And this is the other one we carry, VG1 LifeNet, which is more reasonably priced, $800.
Is it synthetic, both of those?
These are allografts,
Okay.
but they're composites. See how they cut a piece of cortex and they cut some Cancellus and then they put them together. They machine them together with carpentry. The other thing is you can use cement, calcium phosphate cement and calcium sulfate cement. And these are good for articular fractures. Do we carry cement? I don't think we carry cement. Because you can just inject them and then they become incorporated. The calcium sulfate incorporates too quickly. The calcium phosphate sometimes incorporates too slowly, and they're trying to mix these amounts. So the problem with all these demineralized bone matrix is that the amount of BMP that's in there is like 1,000,000 times less than infuse. So like when you say there's a lot of matrices in there, when the evil reps say that there's that it helps bones heal, there's 1,000,000 less in DBM than infuse. Aren't you amazed by that, Peggy? So infuse has 1,000,000 times bone morphogenic protein more than these demineralized bone matrices. And the only thing really that makes bones heal is BMP. So it's kind of amazing. And this was proven from this article in 2006 where they measured how much BMP is in bone matrix products. So that's now Trinity is something a little bit different, and I researched it, and I mean not thoroughly, but Trinity is basically demineralized bone matrix plus some cells, and they centrifuge the cells, and then by an immune process they weed out the cells that are not pluripotential. But the problem with Trinity is that is it enough cells really to get bones to heal? Because like I said, you need like 100 million cells to get bones really to heal.
So where the cells from? From the donor?
Dead people, donors.
That would be having immune rejection, right? You have the
It's possible, and it really hasn't been thoroughly studied because it's not a new device, so they don't have to go through any hoops through the FDA. So you're like, all right, so what? So what does BMP? Well, the Trinity is really expensive. It's like this is a 10 cc's for upper chest speak. They pay $4,000 for this thing. That's almost the same price as Infuse, which is $5,400. So the Trinity is very expensive, and it's not clear if it really works any better than Cancellous Allograft cubes, which is $200. And these are all the other demineralized bone matrix products we have in the bone blood bank. And I just put all the 10 cc'ers so they're all the same. So they go from anywhere $1,300 to $1,200 to $2,800. And then the two most expensive are BMP and Trinity. But BMP really is really proven and is extremely powerful. The problem is it carries risks. So the question is, what do doctors do? I mean, do doctors listen to science, or do they just do what the pretty drug rep says? What do you guys think? They do what the pretty drug rep says. What? What? Yeah. Yeah. And then so this whole thing is like, how can you make sense out of this chaos? And the other chaotic thing is like, we were talking about it, is like nobody pays for nothing in healthcare. Nobody ever pays for nothing, because it's this weird system where, because healthcare is paid with pre-tax dollars and paid through our employer, we really don't see it as being an expense of ours unless you're an employer yourself. Like, I'm an employer myself, and I pay the healthcare. It's expensive, and it's like $1,200 per employee, and then per month, $1,200 per employee per month. It's expensive, and then the healthcare people when they go to the hospital, they don't pay anything usually, unless they have a deductible. They don't pay anything. And then the doctors, we don't pay these. When I surgeon and I use the BMP, I don't pay $5,000.
But you're putting all this money in.
It's a lot of money. I know, but I don't pay for it. I mean, surgeons don't pay for this, so the surgeon doesn't care. It's $5,000. This is a lot of money. It's like it's like $10,000 a case. It's a terrific amount of money that goes to the hospital, but the hospital still makes a profit. Everybody, and the person who really loses is society. I mean, and the winners are these companies that are making, and the companies are basically the managers and the shareholders. It's a weird system.
And in the past 10, 15 years, that's why they push for the OR to give it to the blood bank for the tracking.
Right, so we can track a little better. Maybe separate it from the operating room, but it's kind of not your responsibility. But unless the doctors participate in the costs, I mean, the old way of practicing is like doctors should never think about money, because it's not. Healthcare is about people and happiness and well-being. It's not about money. So doctors were never trained to talk about money or costs, but it's really expensive. So at some point, it's a rock. We're in a society. We're like in a rock and a hard place now. It's extremely expensive products.
Well, doctors want their quality, what they consider their finest quality. Each doctor has their idea.
Right. I know they don't want to. I know, but I mean, someone's got to pay for all this, and it's probably not really worth it. So that's how we end it. So governments. This is the new idea. Is like governments. There's a big leviathan, and we're going to stick healthcare inside of government. That's going to make sense. Right. Is have government take care of all healthcare now. So any questions or comments about bone graft, or that's it?
I agree with you. It's really expensive. I mean, we see the bills. We see how much is used.
$5,000.
I know.
That's a lot of
And the
money.
patient doesn't know what they're getting. They see their statement. They don't know what it is. You know, they just know the insurance company's paying for it.
Well, but the insurance carrier doesn't cover this. The hospital pays for
The
this.
hospital. Well, isn't it part of a procedure cost, maybe?
No, the hospital in the state of Maryland, we get paid per case. We get paid the same amount of money no matter what we do.
Really?
Yeah, I'm pretty sure we don't pass the costs on to the insurer.
It's per procedure, not per item used or whatever. It's like whatever the case is and the procedure name, that's CPT.
That's how they get paid. Yeah, I mean, I don't think so. In other states, they do push the cost to the insurance carrier, and that's why in other states there's a big pushback. They're like, we don't pay for BMP.
Yeah,
It's experimental.
Different.
Mm-hmm.
Maryland's a little bit different, yeah. So the hospital pays these companies. The hospital's the client.
Do you tell patients you're using these grafts? Do you
Yeah.
understand that?
Mhm.
That it's from donors?
Yeah, dead person, I tell them.
I mean, because some people might have some problems with